This is a case of venous stenting of the transverse sigmoid sinus in a patient with pseudotumor cerebri. The patient is a 46-year-old obese female with history of severe headaches, progressive blurry vision, imbalance. MRI was consistent with small ventricles. Lumbar puncture revealed elevated pressures of 46 centimeters. The diagnosis of pseudotumor cerebri was established. The patient has been treated with diuretics, including acetazolamide, without significant improvement. MRV was performed with suggested stenosis of the right transverse and sigmoid sinuses. A patient underwent cerebral angiogram and venous angiography, and pressure measurements were made, which revealed a superior sagittal sinus mean venous pressure of 35. It remained elevated till the right mid-transverse sinus, where it was still 35, and then reduced to right sigmoid sinus to 7 millimeters of water, and this was considered confirmation that the patient was a good candidate for venous sinus stenting. Venous access is established through the right femoral vein, confirming anterograde flow. And through this approach, we gain access going from the inferior vena cava directly into the superior vena cava, avoiding the azagus and the subclavian veins up the brachiocephalic into the right jugular. It's not unusual to encounter some difficulty crossing the proximal valve at the level of the distal jugular. Confirmation is made using an 035 wire by getting access into the sigmoid sinus. The system is then advanced. The 6 French long sheath is advanced typically over a benchmark catheter, which is an 071, which is advanced over a 3 max catheter, which is 3 French. This triaxial system is delivered into the most proximal aspect of the jugular, and then the sigmoid sinus is catheterized, again with the 035 wire system. Crossing the transverse sigmoid junction, and typically either accessing the contralateral transverse or advancing the wire into the superior sagittal sinus. The 3 French system is delivered and an angiogram is performed to confirm the level of stenosis as noted here at the transverse sigmoid junction. Through the 3 French system, then the wire is advanced to gain access to the superior sagittal sinus to give us a longer length of supportive wire and catheter system. It should be utilized to carefully avoid cortical veins. Using this system, the benchmark catheter is then advanced across the lesion, and using that, we then advance the 6 French long sheath as well. Once this is in place, we then deliver the stent, which is typically an open cell device, and simply unsheath the intermediate catheter, delivering the open cell device right sides to the transverse sigmoid junction across the transverse sigmoid space, and as noted here, resolving the venous stenosis. Pressure measurements are performed immediately after performance of the procedure with dramatic reduction in venous outflow pressure.